Hello to all, I'm Dr. Vishnu. So it's actually been a long time since I recorded a YouTube video. If you check my Instagram page, I do post something, I post reels, but when it comes to a YouTube video, which is usually a detailed one, it's been a long time. I was actually, busy with a lot of things. So this is actually going to be a candid video. Candid for what? Candid for antimicrobials. What does it mean? Whatever I have learned, in the clinical perspective, not the theoretical. Theory is important because you get it from the books, you get it from monographs, you get it from people's notes. But there are a lot of things that you need to learn clinically, practical knowledge. So some of the things that I have learned, I have observed. I have been working in the AMS for more than 2 years right now in different hospitals. So whatever I have learned, I'll be sharing it with you. So it's just a candid because a lot of ideas are there, a lot of things I've learned. I'll be sharing with you point by point. So make sure that you subscribe to my YouTube channel, share this with your colleagues, share it with your friends because all the things that I am sharing with you are free of cost. I'm not charging any subscription fees or anything. So at least something that you can do for me in return is, sharing this to maximum people. So thanking you for that and let's begin. So firstly, we need to understand, when you're working in a hospital, there is always a risk of hospital acquired infections, right? Now, hospital acquired infections means what? Like, for example, you have heard of hospital acquired pneumonia, you have heard of, nosocomial pneumonia or nosocomial diarrhea. What does that mean? See, when a patient is getting admitted to the hospital, if the patient is not having any symptoms of pneumonia, right? No symptoms at all. But after 48 to 72 hours of getting admitted, if the patient is developing symptoms of pneumonia, shortness of breath, whatever symptoms are there, there is a scoring system for that. Whatever symptoms the patient is experiencing at least 48 hours after getting admitted is called a nosocomial issue. So if it is pneumonia, then it can be called as a nosocomial pneumonia. If it is diarrhea, then you can call it as a nosocomial diarrhea. So for nosocomial diarrhea, it will be like, three or more than three episodes of diarrhea at least 48 hours after getting admitted in the hospital. So usually in nosocomial diarrhea, what I have seen is clinicians usually prefer to give, metronidazole obviously is given, but they also give tablet vancomycin. Now this is important. Tablet vancomycin. Usually you know that vancomycin comes in, we usually administer it as an injectable. It is indicated for a variety of conditions. It mainly acts against gram-positive organisms. But tablet vancomycin has a specialty. It is given for only one condition, and that is Clostridioides difficile infection. Once again, Clostridioides difficile infection. What is Clostridioides difficile? This is actually a dangerous form of diarrhea which can actually cause pseudomembranous colitis. It can damage your intestines, and this usually happens when you are indiscriminately using broad spectrum antibiotics, and also if you are on chemotherapeutic medications, like your immunity is actually very very low. Now, why broad spectrum antibiotics cause clostridioides difficile? See, in your body, especially in your gut, you have lot of healthy bacteria. And those healthy bacteria have a variety of functions in your body, the most important function being protecting your immunity. When you are using a broad spectrum antibiotic, like for example, you are using tetracyclines, you are using clindamycin, you are using chloramphenicol, you are using fluoroquinolones, right? So when you are using broad spectrum antibiotics, what is the meaning of broad spectrum? That means they act on a variety of organisms. So you are taking that antibiotic for some other infection, but other than killing that bacteria, it will also destroy the normal bacteria which is there inside your system. And this will further reduce your immunity, and it will invite outside pathogenic bacteria to enter into your body like Clostridioides difficile and cause problems. So in Clostridioides difficile infection, Usually the treatment of choice is vancomycin. Vancomycin is not given as injectable, it is given orally. It comes as 125 milligram, 250 milligram doses. So you can have it as, I think it's, capsule form is also available. So you can have it that. And the duration of treatment is usually 10 to 14 days. Metronidazole is also given. And in some other places, we have fidaxomicin also. Fidaxomicin is also another antibiotic that can be given for Clostridioides difficile infection. The short form is CDI. And if none of these treatments work, then the last option is FMT. FMT is fecal microbiota transplantation. Okay. So this is about Clostridioides difficile. So you have got an idea about what is nosocomial infection, nosocomial diarrhea, nosocomial or hospital-acquired pneumonia, HAP, whatever it is. Now let's talk about vancomycin versus teicoplanin. So I'm not into the brands and all, but if you're working in the hospital, you may have heard of Targocid. In most of the hospitals, patients are getting admitted and, we'll immediately start with, in most of the hospitals, it has been seen that, they start with, maybe a meropenem and then they will add a, teicoplanin to it. Actually, the content of Targocid is teicoplanin. So basically, teicoplanin, it is also of the same class as that of vancomycin. Teicoplanin is also of the same class. So vancomycin belongs to the class of glycopeptide antibiotics and teicoplanin also belongs to glycopeptide antibiotics. But there is small difference between vancomycin and teicoplanin. The first major difference is vancomycin causes very significant nephrotoxicity. That is why the trough levels of vancomycin need to be monitored, especially if it is being used for a long term in the patient. But when it comes to teicoplanin, nephrotoxicity definitely is a matter of concern, but not to that extent of vancomycin. That means the risk of nephrotoxicity is actually less in teicoplanin in comparison to vancomycin. Vancomycin is very good for CNS infections. In fact, when patients are admitted with, symptoms of meningitis and you're not exactly sure as in what is the organism in the brain, empirically, vancomycin is given, but teicoplanin is not given because teicoplanin has very poor penetration in the CSF. So that is why usually vancomycin is preferred. So this is some of the differences between vancomycin and teicoplanin. Now in the hospital, you may also see sometimes, infection. Now you need to understand which are the different types of infections that we see in the hospital. Especially I'm talking with regards to microbiology status, that is the microorganism. So some of the common organisms, actually there are a lot of organisms, I can't go into all the details, but some of the common organisms that you will definitely see if you are working in a hospital setup. First is MRSA. Methicillin resistant Staphylococcus aureus, MRSA. Now, what is methicillin? Methicillin was initially a penicillin derivative, and this resistance of Staphylococcus aureus to methicillin developed in the 1940s, during the World War II times and all. So, basically, it means that if you are having MRSA positive in your culture, blood, urine, pus, whatever it is, if you are having MRSA in your culture, you cannot use penicillins. You cannot use cephalosporins. You cannot use carbapenems. And in cephalosporin, there is an exception. You can use fifth generation cephalosporins like ceftaroline, ceftaroline fosamil, ceftobiprole, medocarel. But they are not that much used here. So, we are actually not aware of that much. So basically in our scenario, if we are having an MRSA infection, we usually go for vancomycin, teicoplanin, maybe tetracyclines, especially if you're having skin infections with MRSA. Tetracyclines do excellent job. And these are usually the treatment of choice. So you have to look at the culture report first. So the culture report, in like for example, you have a blood culture report. It will show that it is positive for Staphylococcus aureus, which is an MRSA. You will have lot of antibiotic names. You will be finding which are sensitive, which is written as S. Resistant means R and intermediate means I. So based on that, usually you will see that vancomycin, teicoplanin, tetracycline, these are all usually found to be sensitive. Okay, so MRSA is a very very common, organism, especially if you are having a long term admission stay. Then this infection is sometimes seen. Then let's come to enterococcus. So we have enterococcus two types, which are usually found in a clinical setting. One is enterococcus fecalis, and the other is enterococcus faecium. Now, enterococcus fecalis and enterococcus faecium, these are usually gram positive in nature, and it has been seen in some culture reports that we are getting, culture reports where usually actually initially the treatment of choice was glycopeptide antibiotics, like I said, vancomycin and teicoplanin. But nowadays we are also getting vancomycin resistant enterococci, that is VRE. VRE. So in that condition, the treatment of choice goes to linezolid. So if you are getting a culture report like enterococcus species, and if it is written VRE, then usually based on the culture report analysis, the treatment of choice becomes linezolid. So this is regarding the second organism, that is enterococcus. Then we'll come to Klebsiella pneumoniae. So Klebsiella pneumoniae infections are very common, and Klebsiella pneumoniae is actually a gram-negative organism. And unfortunately, it is seen right now that we are getting amazing level of resistant strains of Klebsiella. So we have mainly two types. One is called the ESBL type, and the other is called almost like the pan drug resistant or multi drug resistant type. So ESBL means what? ESBL is extended spectrum beta-lactamase. So this is usually shown by E. coli, Escherichia coli, and also Klebsiella pneumoniae. In that condition, if you are getting a culture report in which ESBL positive, E. coli, and Klebsiella pneumoniae is found, then the treatment of choice is usually carbapenems. We usually go for carbapenem. You may switch over to some other option if the sensitivity report is positive. Maybe you can switch over to some other agent, but usually the drug of choice for ESBL infections is carbapenems. So we have meropenem, we have ertapenem, right? We have imipenem, whatever it is. So this is regarding Klebsiella, which is the ESBL type. And the much more dangerous type is the pan-drug resistant or multi-drug resistant type. So sometimes in the culture report, you will see that all the antibiotics are resistant. Then clinicians usually go for different antimicrobial combinations. And sometimes it is also seen that only maybe colistin or one or two antibiotics will be sensitive. So it is almost a case of multi-drug resistant infection. So that is also kind of, dangerous type, because these resistant patterns have evolved in recent years. So Klebsiella pneumoniae infection is actually a bit dangerous. So based on the culture report analysis, you can go for the treatment of choice. Then we have E. coli, Escherichia coli. So Escherichia coli or E. coli, this is also a gram-negative organism, and it also comes with the same resistant pattern as I said for Klebsiella. Like we have ESBL type. So for ESBL, I already told you the drug of choice is meropenem, carbapenems and all. And then we have the pan drug resistant or multi-drug resistant type. So based on the culture report, what sensitivity is being shown, based on that you can initiate the antibiotic. So this is regarding E. coli. Now we come to a very, 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 very dangerous organism, and that is Acinetobacter baumannii. Acinetobacter baumannii, usually, if you look at the culture report and if you find Acinetobacter baumannii positive, in most of the culture reports you will find only one or two antibiotics will be sensitive. It will be resistant to carbapenems also. So maybe you'll have to go for maybe polymyxin B, you'll have to go for colistin, maybe you have to go for gene testing and all, and maybe you have to start with this thing. ceftazidime, avibactam plus aztreonam combination and all this. So that depends on the clinician's discretion and based on the culture report analysis in discussion with the microbiologist, the treatment is started. But Acinetobacter baumannii, let me tell you, it's a very, very, very dangerous infection. The treatment duration also goes a long course, and yeah, so because it's also dangerous because the resistant patterns are actually quite high. Then we come to another organism, that is Pseudomonas aeruginosa. Pseudomonas aeruginosa. So the risk of Pseudomonas, actually Pseudomonas mainly attacks your respiratory system. So, it is also responsible for most of the LRTI cases. And that is why, if you are having LRTI, or maybe if you are having hospital acquired pneumonia, and if you are having a risk factor for Pseudomonas, there are certain conditions. Like, for example, if you are having diabetes, if you are having COPD, if you are having bronchiectasis, or maybe some other kind of interstitial lung disease or structural lung disease or anything like that. So Pseudomonas aeruginosa is actually a gram-negative organism. It has been seen that Pseudomonas, shows a variety of resistant patterns, and we have lot of anti-pseudomonal medications, like we have cefepime, we have piperacillin tazobactam, which is anti-pseudomonal in nature. Tisarcillin is not that much used, but that is also anti-pseudomonal. And obviously carbapenems are anti-pseudomonal, but it also depends on the culture report. What I said you right now is theoretical, but if the culture report says that piperacillin is resistant, then you can't use it. So sometimes it has been seen that cefepime is sensitive, so we can start with cefepime. It depends on the culture report analysis. Pseudomonas is a gram-negative organism. Obviously, we have a lot of other types of infections. I'm not going into the details. Maybe I'll make a reel on that, short reels or something. Like we have Serratia marcescens, we have Strenotophomonas, Maltophilia, and we have Morganella morgani. That is not that much common. So we have some other types of infections as well. I'll talk about that later. Now, if you look at the fungal infections, obviously, if you have to develop a fungal infection, it means your immunity is also very low. So this has been seen with immunocompromised patients or patients undergoing transplant, who are the transplant recipients, or if the patient is undergoing maybe on immunosuppressive medications. So or maybe long-term hospital stay and all these things, the chances may be high. So we have different types of fungal infections. We have Candida auris. Candida albicans is very common. We have Candida glabrata. Like that, we have Candida tropicalis. Some this kind of. So it depends on the type of Candida infection that you have. Usually, we go with the azole antifungals first, especially if it is a Candida albicans type. So maybe fluconazole or something like that will work. But sometimes it doesn't. In that case, you have to upgrade to some higher varieties. So higher varieties, like for example, you have to go for echinocandins. Echinocandins are caspofungin, anidulafungin, and micafungin. So they are a bit much more of a higher variety. And obviously, amphotericin B is the last choice. So it depends on the type of. Now, there is one interesting thing about antifungals, which I want to tell you here. If the patient is having UTI, or if the patient is, maybe in the urine culture, you are having, fungal infection like Candida positive or whatever it is, you should not be using echinocandins. And I'll tell you why. Because they have very poor urinary concentration. Echinocandins have very poor urinary concentration. So you should not be using echinocandins. You should go for azole antifungals. Echinocandins should be used when you are having candidemia, like especially if your immunity is low. As I said, different factors how your immunity can be low, and if you are having a fungal infection in the blood, that is the time when you should be thinking about echinocandins. So echinocandins, they have very poor urinary concentration, so they are usually avoided in infections, fungal infections related to the urinary system or urinary tract. So this is one thing that I wanted to tell you. In relation to this, I can talk to you about another antibiotic also, and that is moxifloxacin. Moxifloxacin is an upgraded version, fourth generation fluoroquinolone. Moxifloxacin also has very poor urinary concentration. And that is why in urinary tract infections, bacterial urinary tract infections, moxifloxacin should be avoided. You can go for ofloxacin, you can go for ciprofloxacin, you can go for even levofloxacin, but you should be avoiding moxifloxacin. Moxifloxacin is actually a respiratory fluoroquinolone, so it is actually good for your infections related to the respiratory system, especially if you're having tuberculosis or LRTI or something like that. Okay. So this is something, see, that is why I said this is going to be a large amount of candid information. So please, note it down. You can note it down somewhere. You can save this video also depending on how you want to. But a lot of, clinical informations I'll be, I was actually intending to give you. So these are some of the things that and one more important, very, very important thing. If you look at beta-lactam antibiotics, we have four types of beta-lactam antibiotics. We have penicillins, cephalosporins, monobactams, and carbapenems. In monobactam, we have only one, and that is aztreonam. So usually beta-lactamase is an enzyme which is produced by the resistant organism, and it actually breaks the beta-lactam ring. It's a square-shaped ring. It actually breaks that ring, and so the chemistry of the molecule gets destroyed. So it will not be able to show the antibacterial effect. And that is why we use beta-lactamase inhibitors. Like we have amoxicillin with clavulanic acid, we have meropenem with vaborbactam. Vaborbactam is actually a new beta-lactamase inhibitor. We have cefepime with tazobactam. We have ceftazidime with avibactam, right? So why are these combinations used is because this beta-lactamase inhibitors, they act like a shield in front of the beta-lactamase enzyme produced by the bacteria, and also on the other side the antibiotic. So they act like a shield. So usually they do not have any antibacterial effect of their own because they are just acting like a shield protecting you. It's like a border security force. They act like a shield protecting you from outside insurgency or outside intruders. But there is one beta-lactamase inhibitor, and that is sulbactam. So sulbactam, ampicillin is used with sulbactam. So if you look at sulbactam, sulbactam has antibiotic property. Please remember, sulbactam has antibacterial effect. And sulbactam is actually good for Acinetobacter baumannii. I already told you it's a dangerous type of infection. Sulbactam is actually good for Acinetobacter baumannii. And if you look at the brand name of sulbactam, that the name itself shows its activity. There is a brand known as Acinostop, ACINOSTOP. Acino means Acinetobacter, stop means to protect, to destroy it or prevent it from creating infections. So this is one thing that is interesting about beta-lactamase inhibitors. There are a lot of other informations I'll be coming in future videos. I hope this video has been informative for you. Please share your comments, please share your feedbacks. Also let me know which are the other videos that you want me to work on. My schedule is usually busy. I have a job to do. I have my own study, and a lot of things are there, but definitely I can, make videos in future times to come or future days to come. So thanks a lot for listening to me. I hope this has been an effective learning experience for you. Do share me your feedback. See you in the next video. Until then, it's bye.